All right, if you're getting ready for the NCLEX, you already know hematology questions can be tough. But here's the secret. They're really all about prioritization. It's not just about memorizing facts, it's about understanding the why behind the symptoms so you can figure out who's the sickest. So in this explainer, we're going to break down all the must-know concepts so you can walk into that exam with confidence.
So let's jump right in with a classic NCLEX-style question. You've got 4 patients, all needing your attention. Who do you run to first? Go ahead, read them, pick your answer, and really lock it in. We're going to circle back to this exact question at the very end. Let's see if your answer changes.
Here is our game plan for today. First, we're going to get into the right mindset for the NCLEX. Then, we'll walk through the big-ticket items, anemias, clotting disorders, and cancers. After that, we'll tackle some high-stakes situations like transfusions. And finally, we'll put all the pieces together to solve that first question. Sound good? Let's do it. Okay, before we dive into any specific disease, we have got to talk about how the NCLEX wants you to think. It's a thinking test, not just a knowledge test. It's all about who is the most critical patient right now. These are your golden rules, your North Star for any prioritization question. Of course, ABCs, airway, breathing, circulation, that's always number 1. But right after that, you have to ask yourself 2 simple questions. Is this problem acute or is it chronic? And is my patient stable or unstable? Honestly, getting those 2 questions right will get you the correct answer almost every single time.
All right, let's start putting this into practice. Anemias are a huge topic in hematology, and the NCLEX just loves to test you on the little differences, especially when it comes to patient teaching.
Okay, check this out. This is a perfect example of what I'm talking about. With iron deficiency, the problem is simple. They're not getting enough iron in. But with pernicious anemia, it's a totally different story. It's an absorption problem. They're missing something called intrinsic factor. So it doesn't matter how many B12-rich foods they eat, they just can't use it. And that's why the treatments are so different. One needs a pill, the other needs injections for the rest of their life.
And this is where the NCLEX loves to trip people up. Patient teaching. These are classic safety points. For iron, you have to tell them their stool will turn dark and tarry. If you don't, they'll freak out thinking they have a GI bleed. And for pernicious anemia, the teaching is critical. You have to stress that these B12 shots are forever. It's not optional. And you also have to mention that increased risk for stomach cancer. These aren't just tiny details, they are major safety issues.
Okay, shifting gears. Let's talk about what happens when the body's clotting system just goes haywire. This is where understanding the why, the pathophysiology, is everything. Because you've got 2 conditions that both cause bleeding, but for completely opposite reasons.
Let's really break this down. Hemophilia is pretty straightforward, right? You're missing a specific puzzle piece, a clotting factor. So it's the priority. Give them the missing piece. DIC, though, DIC is pure chaos. It's like a wildfire. Something like sepsis triggers this massive clotting cascade all over the body. You use up all your platelets and clotting factors, making thousands of tiny useless clots, and then you have nothing left, so you start bleeding from everywhere. That's why the priority isn't just replacing parts, it's putting out the fire by treating the underlying cause.
When you see hemophilia on the NCLEX, your brain should scream safety. A bleed in the joint? Your first move is RICE. Pain? Acetaminophen only. Giving aspirin or an NSAID is a huge mistake and a definite fail. And they love to test the psychosocial aspect too. You can't just tell parents to lock their kid in a bubble. Your job as a nurse is to teach them how to create a safe world for their child to play and be a kid in.
All right, let's move into the world of hematologic cancers. With these, a single lab value can tell you a really dramatic story, one that might seem completely backward at first.
So imagine this. You're at the nurse's station, you pull up your patient's labs, and you see this number, a white blood cell count of 350,000. Now, you know a normal count is maybe 5,000 to 10,000. So your first instinct might be, wow, this person has a super strong immune system. But on the NCLEX, that number should set off alarm bells. That number means crisis.
And here's the great paradox of leukemia. That sky-high white count is actually a giant red herring. These aren't strong, mature, infection-fighting cells. They're useless, immature baby cells. And what's worse, they're taking over the bone marrow like weeds in a garden, crowding out everything else. So your patient is actually severely immunocompromised. They're at a huge risk for bleeding because their platelets are low, and they're anemic, all because of that one very misleading number.
Now, when it comes to lymphomas, the NCLEX loves to boil it down to one key difference. How do you tell Hodgkin's from non-Hodgkin's? It's all about one little thing on that biopsy report. Reed-Sternberg cells. If you see those weird, giant cells mentioned, it's Hodgkin's, period. And that's a big deal because Hodgkin's tends to spread in a predictable way, which often makes it more treatable.
In hematology, things can go from bad to worse fast. So let's talk about two high-stakes scenarios that you will absolutely see on your exam: sickle cell crisis and blood transfusion safety.
This is probably one of the most common sickle cell questions out there. Your patient comes in, they're in absolute agony, they're short of breath, a lot is going wrong. But what is the number one first thing you have to do to fix the actual problem?
That's it. It's that simple. Fluids. IV fluids are your number one priority. Before oxygen, before pain meds. You gotta ask why, right? Well, the whole problem is that the red blood cells have changed shape. They've sickled, and now they're log-jammed in the blood vessels. Hydration helps those cells pop back into their normal round shape so they can flow freely again and start delivering oxygen. Fluids fix the root of the problem.
And that, of course, leads us right into patient teaching. Because we don't want them coming back in crisis, we have to teach them what their triggers are. Dehydration is the big one, obviously. But also getting sick, being under a ton of stress, and even going to high altitudes where there's less oxygen can all set off a crisis.
Okay, let's talk blood transfusions. The NCLEX is absolutely obsessed with this, and for good reason. It's a huge safety risk. You have to know these steps cold, in order. First, you prep. Get consent, get vitals, make sure you have a big IV, and remember, only normal saline can hang with blood. Next, you verify. You and another nurse at the bedside, checking everything, no shortcuts. Then you initiate, starting slow, and you do not leave that patient's side for the first 15 minutes. Finally, you monitor. And if you even think you see a reaction, fever, chills, back pain, what's the first thing you do? You stop the infusion. Immediately.
All right, we've covered a ton. The prioritization frameworks, the key diseases, the critical interventions. Now let's go all the way back to that first question and see if we can solve the puzzle using everything we've just learned.
Okay, take another look. Read through the options again, but this time use those frameworks we talked about. For each one, ask yourself, is this acute or chronic? Is this person stable or unstable? Is this finding expected or unexpected? Severe pain with sickle cell, that's expected. A swollen knee after a fall with hemophilia, also expected. A beefy red tongue, that's a classic chronic sign. But a fever in a leukemia patient, is that expected? Is that stable?
And there it is. The answer has to be number 3. And why? Because as we just discussed, that patient with leukemia is severely immunocompromised. A fever for them isn't just a fever. It is a giant flashing red light that screams sepsis. It's a life-threatening emergency. This is a perfect example of our framework. It is an acute, unstable situation, and that always trumps an expected finding, even if it's severe pain.
At the end of the day, the NCLEX isn't really trying to trick you. It's just asking over and over again in 100 different ways, are you going to be a safe nurse? Knowing that a low-grade fever in a leukemia patient is a medical emergency, or that the first thing you do for a sickle cell crisis is hang fluids, that's not about passing a test. That's about knowing how to act when you have a really sick patient in front of you. And that's the kind of thinking that actually saves lives. You've got this.